Thank you all for the opportunity to present our work. The authors have no disclosures related to this project. Although there's been a trend towards increased utilization of minimally invasive surgical approaches in pediatric surgery, there remains a question over the optimal approach for esophageal atresia with tracheoesophageal fistula. Our goal was to compare outcomes based on surgical approach between thoracoscopy and thoracotomy for infants with type C EATF. The Midwest Pediatric Surgery Consortium previously performed 2 multi-center studies regarding esophageal atresia with tracheoesophageal fistula. One was from 2009 to 2014 to identify practice patterns and areas for improvement. The other was from 2016 to 2019 with implementation of a treatment protocol based upon the previous study. We performed a secondary analysis of the combined databases based on the surgical approach between thoracoscopy and thoracotomy. We included infants who had type C EATF and primary repair at a participating institution over these study periods. We also sought to obtain 1-year follow-up data for as many patients as possible, and those without complete data were censored in the analysis. Our primary outcomes were anastomotic leak at 30 days, stricture requiring dilation within 1 year, number of dilations within 1 year, and vocal cord paresis or paralysis at discharge. Regression analysis with propensity score-based overlap weighting was used to minimize treatment bias. This statistical model assists in controlling for bias by weighting patients proportional to their likelihood of receiving the opposite treatment. For our patient cohort, we started with 405 patients from the retrospective database and combined those with 170 patients from the prospective cohort. This gave 575 combined patients, where we then excluded 65 for not being type C, and a further 6 for missing primary surgical repair data. For 504 total patients to be evaluated, with 448 or 88% undergoing thoracotomy and 56 or 12% undergoing thoracoscopy. This chart shows the utilization of thoracoscopy over the study periods. Although overall few patients underwent minimally invasive approach, there was statistically significant increase from the retrospective to the prospective cohort of 9 to 15%. Here we have patient demographics. Notably, there was statistically significant difference in gestational age, weight at operation, and congenital cardiac disease. There were no significant differences in other baseline characteristics, including gender, race, insurance status, or other congenital anomalies. This shows a clear selection bias for patients who are older, heavier, and without cardiac disease being more likely to be offered thoracoscopy. Next are perioperative variables. There's no difference in preoperative vasopressor, prostaglandin, or conventional ventilation. There was no difference with long gap length or use of transanastomotic tube, although there was a significantly increased use of prosthetic material between suture lines for the thoracotomy group. There was no difference in the use of pleural drain, postoperative acid suppression, or postoperative vasopressors. Next are unweighted outcomes. Although rates of anastomotic leak, stricture, and vocal cord paralysis were higher in the thoracoscopic group and mortality was lower, none of these were statistically significant. Additionally, I have Kaplan-Meier curve showing time from procedure to full interval of feeds with no difference between the 2 groups over time, and same with time from procedure to first stricture, no difference between surgical approaches. These are the variables we used in our overlap weighted analysis, trying to find as many impactful factors on outcomes as possible. These are the results from our regression analysis with propensity score-based overlap weighting. All of our ratios were greater than 1 when comparing thoracoscopy to thoracotomy, but again, none of these were statistically significant. We had multiple limitations in the study, notably that despite this being one of the largest cohorts of patients evaluating surgical approach in esophageal atresia and tracheoesophageal fistula, it is still likely to be underpowered due to the limited number of patients undergoing thoracoscopy. Additionally, while the propensity score-based overlap weighted analysis is an efficient method to control for bias, there may be unmeasured variables confounding the results. In conclusion, infants with older gestational age, higher weighted operation, and without congenital cardiac disease are more likely to undergo thoracoscopy. There was no significant difference in any outcomes or complications, and we should take these results with some caution as the study is still potentially underpowered to identify significant differences in outcomes due to the few number of thoracoscopic patients. Thank you. I'll take any questions.
Hey, Brian Gulak from Rush University. Fantastic study, and very interesting, some of your data in there. One point is even at these major academic centers that make up your consortium, it's a very low rate of patients that are still being treated thoracoscopically, and it's a very different skill set than we use in our open procedures. And I think a lot of people have issues where they want to learn to do it, but they're slow to take it on. And one of the big questions I think we have is when you're first starting, how small, what's your size cutoff for doing it? Because obviously a smaller baby is going to be harder. And so I was wondering if you looked at all at looking specifically at cutting off certain cohorts and saying, all right, if we only look at our, under 3 kilos, under 2.5 kilos, did we look, as a secondary analysis, do we see any differences in our rates of our primary outcomes then?
Thank you. That's a really good question. I know from the literature there's definitely multiple studies talking about the learning curve over time for use of thoracoscopy. We did not do any specific secondary analysis looking at those different weights or sizes cutoffs for doing the surgery. And obviously it varied over time which centers were doing how many cases. So I don't think we have the granularity to look at if there are people who are doing it at a certain weight or only doing it at a certain weight. So that would have to be looked at later.
Ben Sendejas from Boston. Great data. Thank you for bringing this to our attention. A couple thoughts and some questions. I think this is, to me, enough data to sort of put that question aside as thoracoscopy versus thoracotomy, because I think that instead of focusing on a technique or approach, there's really, in this patient population, not a one-size-fits-all. And so I think we should start thinking about that as more of a tailored approach to these patients as opposed to like one-size-fits-all. But the other question was, regarding to, I want to bring attention to your vocal cord injury rate. I think that's been an under-recognized morbidity in these patients. You mentioned up to 7% in some of them. And my question was those symptomatic patients, meaning those patients that got assessments based on stridor, vocal changes, sort of in voice?
Only symptomatic patients is what we were able to gather from the databases.
And the reason I asked that question is, in our experience, we found that if we scope every single patient, which I would encourage you to do, up to 20 to 30% of patients have some degree of vocal cord dysfunction. Those are both patients referred to us and our patients. A lot of them are asymptomatic, but they have aspiration on their swallow evaluation, so it's a significant source of morbidity that I think is under-recognized. So I think I would encourage all of us to, instead of focusing on thoracoscopy versus thoracotomy, try to tailor down on these complications, like 30% leak rate, 50% stricture rate. I think we should focus on that.
Absolutely.
Thanks.
Thank you.
As we've been working on doing the long-term follow-up for these patients, we've been looking more at the reflux rate on these patients and the treatments. Did y'all look at any differences between the two approaches in their outcomes for reflux and resolution?
Not specifically with this study. We did capture use of acid suppression over time, which obviously is important for reflux, but no, we didn't specifically look at their need for any anti-reflux procedures or further treatment for that.
We're going to take one final question.
Hey, Matt Clifton from Emory University. My question is about, similar to others, that seems like a low number of patients that actually went through thoracoscopy. Was that number those that finished the operation thoracoscopically, or was it based on intent to treat? Because, a lot of times people will start out that way, but then end up converting. So I just want to know how you broke down the number.
That's a very good question. We did discuss that when we were working on this project. Sadly, we don't actually have the specifics for how many patients were converted from thoracoscopy to thoracotomy. That wasn't a question in the previous database studies, and I did go through the database and look if people had left comments or things about that, but was unable to get enough to say what percentage might have been converted. I'm sure some were, but we aren't able to capture that. Thank you.
Thank you.
Thanks.